Representative Chippendale.
Thank you, Chairwoman. This question would be for the director, the first one, and it is regarding nursing homes. So the cyclical testing that we heard of earlier, Director, and I believe you said it proved that our approach is working, sounded encouraging, but I understand now that testing is taking an exponentially longer time right now than it was in just weeks past. That's concerning to me because I only see that trend increasing as you point out, as the season continues. If we're not able to test quickly enough within a cycle to be able to react accordingly and try to mitigate the impacts of that infected person, I'm not so sure that there's going to be a positive, tangible effect if we're not able to increase not just the accuracy, but also the timeliness of these tests. I think that's more of a statement. It certainly leaves room for you to comment, but before you do, I need clarification because I think at one point we did, or you folks did, implement a policy that I'm not sure is still in effect, and I call it the crossover effect, where regrettably due to our anemic Medicaid reimbursement rate in the state, folks like CNAs will often have to work at two different institutions just to pay the bills. So I can understand where you have a nursing home, the only nursing home in my district left that UHIP didn't bankrupt, has not had a single case. But that CNA working there may then go to one of the other ones where there's a higher occurrence, in fact, a breakout, an outbreak. Is that prohibited at this point for that sort of crossover of employees? Because obviously if they're working in a home where there's a high occurrence, they can very easily contract it and then bring it to their second job and just share the wealth along those lines. So do we have a policy that dictates that they cannot do that?
So thank you, Representative. I'll start with the first question regarding the testing and concern about access given the significant increases in cases. Similar to what we have done with our K through 12 system with education, we have set aside an approach for the testing program in our congregate settings. And so 50% of all nursing homes are receiving direct assistance for swabbing from our 3 mobile testing teams, and 100% receive testing supply delivery. So we really have this set-aside program to help ensure that we can continue through with the cyclical testing. So that's the one I wanted to answer. And then you were asking with the second question with CNAs about movement across congregate settings. We do our best to, number one, help ensure that regardless of the location, the critical staff are able to get tested at the various facilities. We want it to be offered wherever they are so that there is an opportunity, particularly for such staff, to get tested more than once if they chose to. The balance of them working at different facilities is one that we work to mitigate by helping to ensure that screening is done effectively for symptoms, that people have the testing access that's needed, that the personal protective equipment is in place regardless of where they are in the facility. We know that masks, which without a doubt are the #1 tool to prevent transmission. And then what you've heard from the workforce stabilization is intended to help minimize staff having to go to various facilities in order to, survive.
Okay, okay. In that, whatever it is they're doing, whether or not they're going to other homes or not, we're relying heavily, and a lot of your data were compiled of or from contact tracing information. You spoke about that fairly lengthy. I just want to share one anecdote where I stopped at a restaurant for a quick bite a few days ago, and I signed in the book as I was walking in, and I for a moment I thought I was in Hollywood because there were so many famous people on the list, including dead people like Marilyn Monroe. And I frankly didn't trust the accuracy of the phone numbers on there. It was coincidental because that restaurant had just come off of a 10-day shutdown, and I was speaking with my server, and I asked them, why they were shut down. Of course, it was because one person tested positive. Well, why did it take you 10 days to reopen? Because it took them that long to get the test. So I said, okay, did you call all the people on the notebook? Or did the department call all the people on the notebook? And my server kind of laughed when I asked that question and said, look, I work here, and I didn't even get called by the Department of Health. And they knew we had a positive in our building, so no, they didn't call anybody. That was extremely concerning to me. There's a computer term, GIGO, garbage in, garbage out. If our contact tracing is based on, or relying on clearly false information, and then we hear, and maybe it's a one-off, I don't know, but it is an anecdote that indicates that even the department's not following through on the contact tracing when they know of positives being found in a restaurant. That is concerning to me, and I know there's not a direct question in there, but I would like for you to respond to that.
Absolutely. There are two components to your anecdote, which is helpful to explain. Earlier on, and particularly prior to this surge that we're seeing now, the requirement to collect names of people in restaurants were considered and used as one of many tools to be able to facilitate the contact tracing. It was by far not the only tool. What we would do is if there was an individual who was positive, we would speak to the individual, understand and obtain information through case investigation about who their contacts were, be able to call and reach each of the contacts, make sure they also had the information about what was needed, and work with the restaurant, facility, or other place to get the names so that we could verify what we had or fill in any gaps or make any corrections. But we, for sure, from a public health standpoint, know not to, and we don't, rely solely on lists like that, but use it as an additional tool to help fill in the information. It's similar to what we're doing with schools, similar to what we would do with nursing homes. We want to collect any information we have to be able to stop transmission by reaching who is needed. What's happening now with the surge is such a significant exponential increase in cases is requiring us to take different approaches to getting to the individuals who were involved. We know now, this many months into the pandemic, the key component is for people to be able to get tested and for individuals to know what to do. We've seen anecdotally that by the time we call people, many people often already know they're positive, and there are very clear directions on what to do. If you are positive, you have symptoms, whether or not you test positive, you need to stay home. If you're positive, you need to let people know around you as well. Let your employers know, let your school know. Tell those contacts they also need to stay home and monitor for symptoms. We are this far in that this is a message people can respond to. And we know that oftentimes, particularly in a work setting, people have informed each other. And so hopefully the individual you spoke to knew that information, knew that they could and should stay home if they needed to be positive. And at the same time, as we're making the adjustments in this exponential increase in this surge, we brought on 100 new staff within the last 2 weeks. We're incorporating technological approaches about texting people and emailing them. We're doing all the things on our end to help reinforce the message that we're telling the public about what to do regardless, so that it can be a shared responsibility, particularly during the surge when we're seeing record number of cases per day, on how we get our hands wrapped around this.
Thank you. And you are at all of the briefings. I, of course, watch as many as I possibly can. So we have a level of intimacy with these issues that perhaps the general public doesn't. But you stated that there are clear procedures. Another anecdote. A principal from a small Catholic school in the state had one person test positive. I believe it was on a Friday. And for the entire weekend tried to reach someone at the Department of Health for guidance on what to do, and was unable to. On Monday, they were unable to reach out to my office. We dug into it and said, well, who is the contact person for schools to call? There's got to be someone, a hotline. There must be some 24/7 outlet that they can reach out to for guidance. And after 3 days, my office received, as far as information, 2 email addresses. So I will go back and tell this principal, all right, next time you have an emergency, email these 2 people and hopefully you'll hear back, in time to prevent a further outbreak. So while we may have clear procedures, I just want to point out that you and I live this every day, so we're very intimate with those procedures, but we need to be sure that those who we entrust with the care of our children and our elderly loved ones actually know what those clear procedures are, and if they don't, that they have some place they can call. And I mean call, not email. Emails don't get answered right now because everyone's working at a fever pace. They need to be able to call someone, and I would like for you to assure me that there will be, or there is, or there will be someone set up for immediate contact when somebody, and I'm not talking just somebody off the street, but a principal of a school is a fairly important person who should have access to this information, and I think you'd agree with that.
Absolutely. Your question allows me to share with you the extensive number of components that we have in place, particularly for K through 12. So first, we have a K through 12 protocols guideline that's extremely extensive, extremely detail-oriented, that is readily accessible online. We have it for childcare, we have it for K through 12, and spent a significant amount of time working that through with Department of Education, our amazing Department of Health staff, schools, teachers, and all. And we're always so pleased when we hear questions that are, I've read through the protocols of the playbook, I understand this, I just have a question about that component. So that's absolutely in place as a starting point. The second is and probably one of the first in the nation to have done that. The second is, I would need to verify, but really sense that we're probably the only place in the nation that has activated an education operations center that is specifically designed to cater to schools, to principals, to superintendents, above and beyond the communication that we're directly doing from the Department of Health. We work closely with the Education Operations Center, have meetings on a daily basis so that we can always exchange with each other what information or questions are being asked, and readily push out that tool as a source and a place for schools to go. In addition to that, at the Rhode Island Department of Health, we have a full team committed just to K through 12. We have a testing scheduling line, we have a hotline that's available for answering questions. We also have emails where we can get additional questions. We have it worked into our protocol that we do direct reach outs to superintendents on behalf of those principals and the teachers. And when we have the actual case, We have to talk to the teachers as well as the index cases and the principals. So there are multiple layers of communications that are set up in the system to be responsive to school leadership. That being said, while we are going through this surge, particularly in the last couple of weeks, there's definitely an understanding that there has been a challenge getting through. We are thankful that the thoughtful steps that had been put in place before and the fact that we are this many weeks in makes it so that there are fewer and fewer principals and superintendents that are not sure of what to do. They also know where they can go. I myself have joined with the commissioner and had multiple meetings and discussions with the school leadership community about where they can go and what they can do. And as we're bringing on the additional staff, we will absolutely continue that work. And really, I can, it gives me an opportunity to say thank you to our school leadership and partners, because we have really done this together. As they have learned, they're able to do better in collecting the contact information and getting that for us and exchanging it, putting it into their e-ride so we can move quickly and focus on that and being available to answer questions, as opposed to the painstaking work of figuring out for them where people are sitting and what the seating chart is and getting the contacts. Doing it as a partnership allows us to free up space to respond to the higher number of cases as well as to the questions that come through.
Okay, so can you just provide that hotline? Because that's the one thing that I did not get from your office when I inquired. I just got the name of the epidemiology operations team that you referenced. 2 emails, that's all I got.
Okay.
Well, the Education Operations Center is the best reference for principals, and I don't have that number memorized, so I know Neil and our amazing staff is listening, and we'll get that for you, Representative.
Much appreciated.
Okay,